everyone. So my topic is intravitreal anti-VEGF injections, what, when and how. So I want to thank my mentor, Dr. Khan, for giving me the training, what I am doing in the retina because of him. So the introduction of drugs through the pars plana directly into the vitreous. It is the gold standard for many retinal diseases. So it is a highly targeted treatment, and by giving intravitreal injection, maximum therapeutic concentrations with minimum side effects are there. So when we talk about the history, in 1911, the Dukemans and Ohm injected air bubble to tamponade the retinal detachment. And in 1944, the intravitreal penicillin was injected in endophthalmitis cases. And in 1970 to 74, the successful treatment for the endophthalmitis by this route. And in 1988, that is Vitravine for the CMV retinitis was approved by FDA. So there are various anti-VEGF injections. So the indications we all know, wet AMD, macular edema, diabetic and retinal vein occlusions, BRVO, CRVO, choroidal neovascularization, PCV, ROP and neovascular glaucoma. So when we talk about that is anti-VEGF injections, they are ranibizumab, bevacizumab, pegaptanim, aflibercept, brolucizumab, faricimab, and biosimilars. So in steroids, we have triamcinolone, dexamethasone, and fluocinolone, and also dex implant. So by pictures, we can, VEGF is the vasculoendothelial growth factor. Anti-VEGF agents block the VEGF molecules and thus benefit the patients by decreasing the abnormal and the harmful new blood vessels formation and by decreasing the leakage and the swelling of the retina. So what is the VEGF family? So the anti-VEGF mainly targets the VEGF-A level, and the VEGF-B, C, and D, they are also known for the vasculogenesis, and PIGF important for the vasculogenesis. So the most of the anti-VEGF, they target the VEGF-A. So in the angiogenesis, there is a migration of the endothelial cells, increased mitosis of the endothelial cells, increased matrix metalloproteinase activities, and chemotactic for the macrophages and granulocytes. So vasodilatation indirectly by the aneurysms. So the common indications, they are at the AMD, venous inclusions, diabetic macular edema, CNVM, neovascular glaucoma, and the preoperatively we can give in PDA surgeries and the vitreous hemorrhage cases. So the indications, previously the vein vasculitis was known as Eales disease, refractory post-surgery CME, Court's disease, ROP, ocular tumors, we can try that, macular edema due to the, that is radiation retinopathy, then iris neovascularization, and pterygium, there are many studies they have used in the pterygium also, trabeculectomy for the wound healing modulation. So the contraindication. So whenever there is a fibrovascular proliferation which is threatening the macula, it is absolute contraindication. So the active and the periocular inflammation, and then it is contraindication if the patient has a recent stroke within 3 months, then it is contraindication. And patient hypersensitivity to ranibizumab or bevacizumab, which is very less known. So first of all, in pegaptanim in 2004, it was launched, and in 2006, the ranibizumab was launched. Then after that, aflibercept, and then after that, brolucizumab, faricimab, and bevacizumab is still used in that is underdeveloped countries because of its low cost. So the newer anti-VEGF, brolucizumab 6 milligram and faricimab 6 milligram. So it is so this is, we can see this table, that the bevacizumab and ranibizumab, these are the recombinant humanized monoclonal antibodies. And aflibercept, that is recombinant fusion protein, and pegaptanim is the pegylated aptamer. So brolucizumab is a recombinant human monoclonal antibody. So in the size, we can see that the brolucizumab is of the molecular weight is 26 kilodalton. So it has the highest affinity for VEGF-A levels, whereas the Eylea has affinity for the VEGF-A, B, and PEGF. So the adverse effects can be the ocular endophthalmitis, there can be the ocular hemorrhage in the form of subconjunctival hemorrhage, there can be the raised IOP, cataract, if you have hit the lens, that is the Rose's type of cataract you can see after that. Then the retinal tears, if you have gone before the 4 mm, and then intraocular inflammation, it is more commonly noticed with brolucizumab, and rarely you can have the very less known complications such as the retinal toxicity. And the systemic contraindications, MIS I have already told, and deep vein thrombosis, pulmonary embolism, and thrombophlebitis. So in the injections, we have 3 injections, and the indications I have already told. So the Ozurdex, it is the FDA approved, that is extended release intravitreal dexamethasone implant, and that is, it lasts for 3 to 6 months. So the adverse effect, that is cataract formation, and then is IOP rise, and very rarely it can cause the endophthalmitis. So pre-injections, that is always confirm the name of the patient and the eye of the patient, and confirm again the indication and the type of the intravitreal injection. When you are using the bevacizumab, because it is off-label use, so it is very important to explain the patient all the other options also. So the equipment is sterile, raped, then it povidone in the eye for the 5%, and that is on the lids 10%, and then it is usually given on topical anesthesia, and that is 2 to 3 minutes after the povidone iodine painting we should wait for, and a sterile speculum should be used, and the topic under all sterile conditions we can inject the that is intravitreal injections. So to minimize the risk of endophthalmitis, that is povidone iodine usage, and while when we are injecting, we should not talk. So the face mask is very important. So the gloves and the pre-filled syringes, and you can use that is the 30 gauge needle, and the distance has to be maintained. If the patient is pseudophakic, 3.5 mm, if the patient is phakic, then the 4 mm. So according to the age, the distance of the injection from the limbus, it is very important. And less than 6 months, that is 1 to 1.5 mm, and then less than 1 year, 2 mm, then 2 years, 2.5, and then that is in the normal age group according to the status of the lens. So with the help of 26 gauge needle, you can inject the injection. 0.05 ml. This is a small video showing how to give the injection, most commonly in the inferior temporal quadrant. Always ask the patient to see opposite to the quadrant. Then override the conjunctiva over the lesion with the help of the swab. And if you are not sure, always use the caliper to be sure of the distance. And that in cases of DEXA implant.
Ma'am, time is up. Can you conclude?
Okay, just this video only, sir. So in this case, you have to go through making a tunnel, so that because it is a big gauge needle, so you have to take care of you have to make a tunnel, and then enter into the vitreous cavity. And most commonly, it can be given in the inferior nasal quadrant. So in the ROP babies, in the subsequent lectures, they are discussing the retinopathy of prematurity, and brolucizumab will be discussed in detail. So I will be leaving that. Thank you so much.
Very comprehensive presentation on anti-VEGFs, and compressed into a few minutes. It's not easy. So any questions, any comments, judges, co-chairman, audience?
Tricot injection, any special precautions when you give intravitreal triamcinolone acetonide?
Before giving any that is steroids, we should look for the intraocular pressure before giving the injection, and also the status of the disc is very important.
So how do you...
and if the patient is a phakic also, we can avoid that also, the DEXA, and because there are high chances for the cataract formation and the glaucoma in that cases.
So this can form precipitates inside in the vitreous cavity. So better to give it in the lower quadrants rather than the upper quadrant, so that it doesn't come into the vision.
Yes, sir. Yes, ma'am.
Thank you.